Hello everyone, good afternoon and welcome to today's webinar in partnership with Vitality and Check for Cancer. My name is Jamie and I am part of the coaching team at Vitality. Now, the subject of our event today is one which will affect 1 in 2 people during their lifetime. And last week, I was really fortunate to attend a 2-day retreat to Champneys with a group of ladies who are recovering from cancer. And it was a real privilege to hear their stories and to spend some time with them. So the conversations we are having aren't exactly easy and they can be pretty deep at times, but they're also really essential. So for anyone joining today, please do exercise some self-care. And the message throughout this one today will be simple. It's seek medical support if you have any concerns at all. Now, it's been well documented, I think, that the impact of the pandemic has been significant for patients with time-critical conditions such as cancer. The disruption of cancer services is a global phenomenon, but the suspension of screening services and the failure to protect cancer services in the UK has resulted in 40,000 less cancers being diagnosed in 2020 compared with 2019. And the fear is that we haven't actually seen the effect of that just yet. So for today, we're super fortunate to have Professor Gordon Wishart sharing his knowledge with us. Gordon is the founder, CEO and CMO of Check for Cancer, a leading early cancer detection and cancer prevention organisation. There are more than 55,000 new cases of breast cancer and 3,200 cases of cervical cancer diagnosed in the UK each year. Cancer research, though, has suggested that 23% of breast cancer and 99.8% of cervical cancer cases would be preventable if appropriate screening procedures were implemented. So today we'll be providing information about the signs and symptoms of these cancers and helping people understand their own personal risk and encouraging them to use the diagnostic pathways. So we're also incredibly grateful to be joined by Vitality members Lisa and Jessica, who have been through the cancer treatment and are going to be sharing their experiences, their learnings and providing some valuable advice. And it's really impactful, I think, to just hear these real life stories, because we've all heard it before that we all know people, but you never expect it's going to happen to you until it actually does. And then the final part of this session will be dedicated to you and it'll be a Q&A. So please do locate on the right-hand side of your screens, there'll be a question box in there. So get involved in the conversation. We'll do our very best to cover as much as we possibly can. And now is the time to ask questions. So please do not leave wishing you would have asked your questions. We have such an expert in Gordon with us today that I think this time can be so valuable, not only for yourselves, but for supporting everyone around you as well. So Gordon, you're always incredibly generous with your time and you're a true expert in the field. Hopefully you're there with us today. How are you doing? I think you're on mute, Gordon. I'm so sorry to do that to you.
That's it now?
You're on. Gordon,
yeah,
how are you doing?
Yeah, good. Good to be with you again. Tackling these important issues and subjects.
Amazing. Thank you. Thank you as always. Gordon, we've got a lot to cover today and we're specifically focusing on breast and cervical cancer, given that our theme for this month is women's health. I know that there's going to be much more that people need to know, but today if we specifically focus on these areas, we're kind of going to be talking through the signs and symptoms, the screenings, the diagnosis process, looking at treatment options and an explanation of what will happen, the effect of the pandemic, and then obviously how Check for Cancer and Vitality can support. So we're going to break it into 2 sections. We'll focus on breast cancer first before moving on to cervical cancer. So it's a very common question, Gordon, but one that we cannot keep asking enough. Signs and symptoms of breast cancer, what's the sort of things that we should be looking out for?
Well, I suspect everybody would know that one of the commonest ways that breast cancer presents is with a lump in the breast. So a new lump in the breast. It might be more concerning if the lump is hard to touch, if it feels irregular, particularly if it's on the inner part of the breast. So a number of things, but any new lump should be investigated via the GP. But there are a number of other signs. New inversion or retraction of the nipples, so the nipple is pulled inwards. It's quite common to get some discharge from the nipple. But if there's any blood within that discharge, that's another thing that should be checked out. And then just sometimes there's a change in the shape or the projection of the breast. And that's why we ask people to, to check by looking in the mirror and raising their arms to see if there are changes in asymmetry between the breasts. So a number of different things, but essentially if you notice any new change in your breast, you should get that checked out, and you would see your GP and you would expect to be examined before being referred on for further investigation.
And to everything that you mentioned there, the main point was about any change, really. So I guess one of the key messages is get to know your own body as best as you can, as soon as you can. Is there any way in particular that we should go about doing that?
Yeah, I think you're right to pick that out, because if you are going to notice changes, you need to know what your breasts change and feel like. I think if people are going to, be breast aware and perhaps examine themselves, you're best to do it at the same time each month. Usually in the second half of your menstrual cycle, when your breasts are less lumpy, that's a good time. Looking in the mirror, you should be standing up, and you should look at the shape of your breasts and their position standing up with your arms by your side and your arms in the air. And then if you're going to examine yourself, you should do it lying down. So on the bed or in the bath. If you examine yourself standing up, then lots of the breast tissue overlaps and you feel things which are not real. So if you are going to examine your breasts, best to do it lying down.
Perfect. Amazing. Thank you, Gordon. And then I guess kind of moving on, if there are any abnormalities or things that you need further support with, the screening/diagnosis process, is there a standard process that people will go through? And if so, what does that kind of look like?
Yeah, the process for investigating people with new breast symptoms hasn't really changed since the late 1980s, and it's something called triple assessment, and that just means you should get access to three things if you require them. One is an examination by a consultant, some form of breast imaging, which if you have a lump will usually be a breast ultrasound scan, and if you're over 40, a mammogram as well. And then if a lump is picked up in any of these ways, then you would have a biopsy under local anaesthetic. Now, the gold standard is that these should all be delivered at the first consultation. Unfortunately, I know a lot of hospitals struggle to fulfill that, but it is best practice. And we know that if you do it in that way, then you'll make the right diagnosis in over 99% of cases. And we know that because we did a big trial in Cambridge where we showed that was the case. So I'm a big advocate of, one-stop breast clinics where all investigations can be done at the first appointment. But if they are spread over several appointments, it's not quite so good for the patient, but it should achieve a very similar outcome. Okay,
that's pretty encouraging, that percentage in terms of successful diagnosis. And I guess we are covering a lot today. So moving on, if you did receive the news that you had breast cancer, from the work that we've done before, there's often options with treatment. So, and the people that we've spoken to and worked with have often said, and I'm sure Lisa and Jessica might be able to elaborate a bit on this for us, they're not in the headspace or the mindset to want to be making those decisions. And Gordon, you used to be a breast cancer surgeon. So when someone is diagnosed and then the next step is to talk about the treatment options, how does that process work? And I know that you've also developed a model as well, and I don't know if now is a good time to bring that in as well.
Yeah, I think there are two parts to this. The first part is during the first appointment, if you think someone is likely to be diagnosed with cancer, I think it's really important to say that at the time, so that a week later, no one's ever fully prepared for that diagnosis, but you're a bit better prepared if you've had a week to think about it. And what that means is during that second consultation, once you have the biopsy result, it's much easier to focus on the treatment rather than the devastating impact of hearing the word cancer for the first time has. In breast cancer, the treatment options are very much tailored to the patient and the characteristics of their own tumour. And so there are now a wide variety of different treatments. Of course, everybody will have heard of chemotherapy and hormone therapy and radiotherapy, but there are lots of nuances to the way that treatment should be delivered and in what order and what combinations. And you're right, in Cambridge we did build a model called Predict, 10 years ago, which is now used, worldwide, and it helps patients and their doctors decide what are the best treatments, because it allows you to calculate the individual benefit of each treatment. So if a benefit's very low, you might not use it. If it's very high, you would definitely recommend it. And these types of models are becoming much more commonplace, not just in breast cancer, but in other cancers as well.
I think that's quite comforting to know that there's tools in place to help you make an informed decision, because again, like from listening to people generally, you are entirely reliant on your surgeon and the people that are supporting you, and you just want them to help. So having as many and as much information as possible, I'm sure, is a massive support for that. I mentioned in the introduction about the effect of the pandemic. And obviously, Gordon, and I know you've written a lot about kind of the effects and how this might make differences going forward as well. So I guess, what would your message be to people now about where we're at in the journey and the availability of diagnosis and treatment and things like that?
Yeah, I think the backlog was so big. As you said, there were millions of people that missed their screening appointments. I know the NHS is trying to catch up with those appointments just now, but it is under, a lot of pressure. There's not a lot of reserve capacity in the NHS to catch up with such big numbers like that. So I think the thing I would say is that if you've had your screening appointment delayed or deferred or cancelled and you get a chance to have it, I would really encourage you to go and have screening. I know screening's not for everyone, and there are pros and cons of screening, but I think it's certainly one of the ways to pick breast cancer up as early as possible. And something like 20% of all breast cancers are picked up normally through the screening program. The other thing is, as we discussed earlier, if you do notice any new changes, then you must go and get them checked, because again, the signs and symptoms of breast cancer tend to present quite early. And so even if you've not been detected through screening, there's still a good chance that your cancer will be detected at a stage where it's still very, very treatable and the outcome can still be very good. So I think either accessing screening or getting any new changes checked out as soon as possible would be my main two messages.
Amazing, thank you. And just finally, in terms of what Check for Cancer can offer and how that process works, do you just want to share a little bit of detail on that?
Yeah, so as a company, we're very interested in offering screening to patients, making them aware of the pros and cons. We do offer screening mammography. We have a network of places where women can get access to screening mammograms. And then Vitality and Check for Cancer have worked for a very long time. And we have access, we run a network of one-stop breast clinics. So those are the clinics where you do get all your tests done on the same day. So we've helped lots of Vitality members and other patients as well be seen as quickly as possible. So be seen at the right time, in the right place, by the right consultant, and have the right investigations.
Yeah, it's an amazing service, and please do make use of it. If you need to find out more information, head to the Vitality Member Zone or just Check for Cancer website, and there'll be all the support you need there. Gordon, I'm just going to recap on those signs and symptoms before we move on to cervical cancer, because I think that's probably an area, if nothing else, that we are aware of today. So we spoke about any new lumps, inversion of nipples, blood discharge, changes in the shape or projection of the breast, and having a monthly examination is crucial to that, keeping it at the same time, doing it lying down, and just getting to know your body as best as possible. Have I covered everything there?
I think so. I think it's just worth mentioning that a lot of people get very worried about pain in their breast, but pain is actually quite a common symptom. It is possible sometimes to have something significant going on in your breast and have pain as well. But I think it's reassuring for people to know that breast pain is not usually a sign of breast cancer.
Perfect, thank you for clearing that up. And we are getting loads and loads of questions. Please do keep them coming. We will cover as much as we can. We're going to move on now to cervical cancer now, as we're focusing specifically on women's health. The structure is going to be exactly the same. So this part of the webinar is very factual and hopefully just providing you with the information that you really need to know. So cervical cancer, I think, Gordon, I don't know if this is correct or not, but seems to be one with a little less awareness in terms of particularly the signs and symptoms. So would you mind kind of sharing what things we need to be looking out for there?
Yeah, absolutely. So there are a number of signs and symptoms of cervical cancer. So one is unusual vaginal bleeding, so at a time when it shouldn't be happening, and that would include vaginal bleeding after the menopause. Painful intercourse is another sign of cervical cancer. Vaginal discharge, especially if it's particularly odorous. And then more general symptoms like losing weight and kind of general lower abdominal pain. So a number of signs and symptoms. And as you say, I think they are less commonly known. I think more people know about cervical screening and getting the vaccine when you're young, and we'll maybe talk about those. But it is important that if people have these signs and symptoms we've just mentioned, that again they see their GP and hopefully get them checked out.
That's a really good point, and we have had a couple of questions on this. Is it difficult to distinguish between what's normal and what's not, given those symptoms, do you think, or is it something that would be very noticeable?
I think, sadly, in some cases, these diagnoses creep up and because it's not apparent. But I think so. I think the term unusual is good. Something that's not usual for you. So you maybe have a very regular cycle, a menstrual cycle, and then it changes, and you perhaps might have some of the other symptoms that we talked about. So it's really unusual and or prolonged symptoms, which I think it's very similar to when we're telling people what to look out for if they've had treatment for cancer and they're worried, what to look for when it comes back. We often talk about unusual and or prolonged symptoms that are unusual for you.
Yeah, it's such a common theme with everything health and well-being. It's the individualized approach, like for you, and you need to have confidence in knowing your own body, and that reaches into the less important topics of just keeping fit day to day. You need to figure out what works for you. So the symptoms, signs and symptoms are going to be individualized, but then the screening process, how does that work with cervical cancer?
Yeah, so I mean, there's really quite a big preventative program for cervical cancer in the UK. So cervical screening has been around for a long, long time. And so that now starts at age 25 in the UK. In the NHS, and women are invited for screening every 3 years. The reason that it doesn't start at a younger age, and there's often a clamour for it to start younger than that, especially if someone is diagnosed with cervical cancer before the age of 25. The reason it doesn't start earlier is that all cervical cancer is due to the human papilloma virus, HPV, and it's a sexually transmitted disease to which we will all be exposed to at some point, but the majority of us clear it from our system with our own immune system. So we knock it out and it doesn't cause any lasting damage. But in a small number of women, it persists and over many, many years causes cervical cancer. So in the under 25s, there's a lot of us that have transient HPV infection, which could be picked up and then perhaps overtreated. Beyond age 25, it's less common, and you tend to be picking up women with infection, HPV infection that's more established and therefore more likely to cause cervical cancer in the long term. So screening is really important. Then since 2008, we've been vaccinating 12-year-old girls. And so the people that first had that vaccine are now getting to age 25 now and will be entering the screening program. The combination of successful vaccination and screening should eradicate your risk of getting cervical cancer completely, which is a great thing to be able to talk about, with any cancer. But it does mean that you would need, 100% compliance with both of those, which is still not the case. So I think when we have a cancer like this that can have a really quite a poor outcome if diagnosed at a later stage, and there's something we can do about it by preventing it happening, then that's got to be a good thing to do. So I'm a great supporter of both cervical screening and HPV vaccination, which is now being given to 12-year-old boys as well. So it's 12-year-olds that are getting this because obviously they can spread it as well if they become a carrier.
literally had no idea. Like, and I don't think, and I'm not naive to these things. Like, this is an area that we work in. So the fact that we don't know, I think it's probably common that lots of people don't know. So that's so useful. And in terms of, we covered treatment options before, but I think that we need to be clear that we're not actually going into treatment options because there are so many, and that's a whole nother session in itself, which we may well do sometime, and I think would be valuable. But how does the treatment process look in terms of options, and what sort of conversations will be had, I guess, if you are diagnosed with cervical cancer?
Okay, but through the screening program, more people would be picked up with really some of the changes happen before you get actual cervical cancer. So there's several stages that the cells go through from normal to that, final cancer diagnosis. If you pick those up early, then they can be treated by just, killing those cells on the outside of the cervix. There's a variety of ways to do that to prevent them going on to become cancerous. And there's some great techniques now that show you the cancerous cells on the cervix, and you can just destroy the appropriate areas. If someone, actually, if that process fails and someone is actually diagnosed with cervical cancer, then the usual treatment would be hysterectomy to remove the uterus and the cervix, which is part of that. But what we really hope to do is try and, offer much less treatment at an earlier stage to stop it getting to that point.
So I think the message for cervical cancer is clear, that time getting the treatment initially is the most important thing. Gordon, this wasn't necessarily part of the plan, but because we have had so many questions, I think that they're kind of maybe ones that we can just get through a little bit now whilst we're on this topic of breast and cervical cancer. So it's okay, I'm going to chuck some of those at you.
Yes.
First one being the effect of the contraceptive pill for risk of breast cancers. Do you have any information on that?
Yeah, if you look at all the published evidence, that there's probably a very, very small risk, but it's actually, over the years, the evidence, I think, has got less and less. So I think it's obviously a very effective method of contraception, and I think the increased breast cancer risk is probably negligible.
Okay, thank you. Next one is about just a couple more signs and symptoms potentially for breast cancer risk. Is itching and erect nipples a sign?
No, itching is much more a sign of inflammation. Sometimes you get, runners tend to get a kind of itch around the nipple, just with the kind of abrasion. You can get dermatitis and eczema around the nipple. So itch, not really a worrying sign. And what was the other one you said?
Erect nipples.
Yeah, no, it's just a kind of overactivity of the nipple, so not worrying. It's when the nipple is pulled in the way and you can't bring it back out, that's a much more worrying sign.
Okay, cool. Thank you for clearing that up. How old do you have to be to get a routine mammogram, like a smear test?
A screening mammogram, if you're at average risk of getting breast cancer, then the screening program will start at age 50, and you'll get mammograms offered to you every 3 years until you're 70. If you're in what's called the moderate risk group, which is usually because you have quite a strong family history of breast and or ovarian cancer, you also get yearly mammograms from 40 to 49, and then you enter the more traditional screening. And people who are very high risk and maybe carrying one of the breast cancer genes, the BRCA genes, they will start even earlier, and they'll also have MRI screening as well as mammography.
Okay, amazing, thank you. And then final one for now is about, are you able to go for breast screening without symptoms? For example, if you just wanted to pay for a private scan, you're younger, you just want to be safe.
Yes, so that's a very good point. Breast screening should only be for people without symptoms. If you're worried about a change in your breast, then you should go down the diagnostic pathway that we talked about earlier, where you actually go to a clinic, you see a consultant, you get examined, and you have tests that are relevant to you. The screening, by doing screening mammograms, you should not be aware of any changes in your breast if you go for that. So they're two very different paths for screening and diagnosis. And screening's no symptoms, diagnosis is for women with symptoms, and men with symptoms as well.
I'm going to say that line again. You said screening should be only for those without symptoms.
Correct.
Cool. Hopefully you've made that clear enough. And I'm just going to, as we did with signs and symptoms for breast cancer, just recap cervical cancer. So the signs and symptoms that you want to be aware of: unusual vaginal bleeding, including post-menopause, painful intercourse, losing weight, general pain, odorous discharge. Are they the main things? Have I missed anything?
Yeah, no, I think those are the main things, Jamie.
Perfect. Gordon, as always, you're so helpful and informative, and hopefully I think we're getting a lot of comments saying how simply you've explained it, which is really, really helpful. So thank you. Gordon's going to stay around for this next section where we're going to talk to two of our Vitality members who were diagnosed with cancer, and they've been through the treatment process and are now here to share with us their stories as well. So I'm going to first introduce Lisa, who, Lisa, I'm going to let her tell a story, but she's got a couple of young kids. They were under 10 when she was diagnosed. She works full time, and just for context, she's also an enthusiast for mud running, which is pretty cool. Just a fun fact to share. Lisa, are you there?
Yeah, I'm here.
Hello. Have you got your camera on? There you are.
Yeah.
How are you?
Hi all. Hi there, mate. Good, thanks.
Nice
You?
to see you. Yeah, very good. Thank you so much for joining us. So Lisa's been kind enough to just be open with sharing her story. So we're going to sort of talk through the initial checkup, why she went even to the doctor in the first place, what the diagnosis process was like. We might cover a little bit of the psychological impact, treatment, and then Lisa's also going to share some advice too. So Lisa, if you wouldn't mind, in your words, kind of talking us through what made you go to the GP and have a checkup in the first place.
Sure, thank you. And also thank you, Gordon, for your advice at the top of the hour, because interesting, I've always been fairly breast aware, but one of the things that you just said there is I've always done it standing up. And you've mentioned there is make sure you do it lying down. And it's interesting, a lot of the leaflets that you see out there is people standing against the mirrors and doing the test, not lying down. So I've learned something straight away. So thank you for that, Gordon.
Good.
Thank you, Jamie. Yeah, and thank you for inviting me. Mine was, I guess, kind of the typical, it sounds wrong to say, doesn't it? But the typical diagnosis. I did feel a lump in my breast last May in 2020. May 2020, during COVID. And then I kind of thought, oh, it's probably just a cyst. I won't lie, I did think that. I just ignore it, even though it was quite hard and it was quite irregular. So it was kind of rectangle, I call it. It was long and very hard to touch. But I kind of thought, it'd be a cyst. I'm sure it's nothing, etc., etc. Left it for a little while. And then I thought, oh, no, it's not kind of gone away. And then I contacted my GP. Forced them not to do it over Zoom because they wanted to check me over Zoom. But luckily, when I spoke to the GP, she was very helpful and said, come in straight away. She seen me and then basically said, oh, I think this seems abnormal. We'll send you straight away for referral. I got referred. By about 2-3 weeks later, I got a letter to come into the breast clinic. The people in the breast clinics were absolutely fantastic. I had mammograms, I had the ultrasounds. It was confirmed there and then. They also took the biopsies, which Gordon said there at the same time as well. So they kind of took the whole lot over a period of a few hours. And then at the end of it, they told me the news, which was, it wasn't negative, it wasn't positive. They said on a scale, I'm not sure, Gordon, if this is what you normally do, on a scale of between 1 and 5, you're probably a 2.5 to 3, the likelihood that you may have breast cancer. So I kind of took it, well, okay, I'm 50-50. I really took the 50-50 version. And because the biopsy, they just take the biopsy to confirm it, I kind of went home thinking, well, actually, I'm healthy on fish. I don't drink much. I don't eat rubbishy food, bar the odd sweet things. I do a lot of exercise. I don't have it in my history. So I kind of erred on the side of 50-50. I think I'd be fine, not to really worry. Although there was that little thing in the back of my mind that was concerned. So I left there thinking I'll find out in 2 weeks' time, either way. And then a few weeks' time, I think it was about 3 or 4 weeks, it was delayed because of COVID a little bit. And then they rang me to say, Lisa, can you come in and bring someone with you, because we've got to, we'll go through your diagnostic results. So I won't lie, at that stage, I kind of triggered when they wanted me to bring someone, there's something going on. When I got into the clinic, they sat me down and said pretty much straight away, we're really sorry, Lisa, but to tell you that you have got invasive ductal cancer, and it's a high grade, grade 3. And pretty much all I thought straight away, I won't lie, God, I've got cancer, I'm dying. That's the first thing that came to my mind. I think I zoned out for about 5 minutes. My husband was with me, who was fantastic, supporting and kind of talking to them. And then the consultants went through the options and said, we think, Lisa, you may need, we'll do a mammogram, we'll do a mastectomy on you. And that's the first course of treatment. And when I heard that, I thought, hang on, do you need a mastectomy? Can you check me out? And they said, well, we can also give you options of breast conserving surgery or mastectomy. And then they had a look at me and decided which option. But it was one of those things that they give me an option straight away. And it was kind of say, well, what do you want to do, Lisa? And I'm thinking, I haven't got a clue. This is beyond me. I really don't know. And then they said, we'll leave you to go overnight to think about it if you're not sure now, but we really kind of need to know within the next 24 to 48 hours. And pretty much I said there and then, okay, do what we need to do. And we continued down that road. And the consultant that had seen me said, okay, she checked me out. She said, actually, we might try and do some breast conserving surgery with you. And she'd written a thesis actually on it. So I said, yeah, I'm fine with that. We'll go ahead with that. I said, if worst case, if it's worse than you think, then take it out. Do whatever you need to. A few weeks later, then we had the operation. They did the breast conserving surgery and also tried to make the remaining of my breast look better. There's probably some fancy word for that, but I can't think of it this minute. Reconstruction, but it was partial reconstruction. And then they took some biopsies of at the same time they took my axillary lymph nodes out, which is nearer to the breast. They took a biopsy on that, and a few weeks later that came back as positive, that I had spread to the axillary lymph nodes. So then they rang me back again and said, Lisa, we need to take another operation to take your lymph nodes, all your lymph nodes out. They removed all my lymph nodes a few weeks later. And then after that, they had also done some diagnostics about where I had spread to within the rest of the lymph nodes. And they had said at that stage, Lisa, we'll give you some options of chemotherapy or radiotherapy. This is the route we might want to go down. And the consultants, I won't lie, all the way through have been absolutely fantastic. They've been really clear of what they wanted, but ultimately it goes back to some conversations we had earlier, was they do kind of give you an option, and I was again not in a state to go down the chemotherapy route or the radiotherapy route. And then after a bit of conversation, they said, okay, Lisa, we think you need chemotherapy. This was all, of course, on a conversation over a phone call, because you can't see them face to face. And that was the trickier thing, because you're there talking to them for 5 minutes and it's those back and over. You don't see the nuances when you're speaking to someone over Zoom or if you're speaking to someone face to face. So anyhow, the result was they recommended eventually was chemotherapy and radiotherapy. So I started actually today, the 22nd of October, was when I started in 2020, a year ago today, I started my chemotherapy journey. And I started on one called FECT, F-E-C-T. Don't ask me what that stands for. That's a lot of big words, but I know it was very brutal. I had that every 3 weeks. And I won't lie, I went into chemotherapy quite naive, because I've seen lots of people on all those Stand Up to Cancer and all those shows. And they show two versions of people with chemotherapy. One that's kind of bedridden, and one that's almost dancing around with the pumps attached to them. I was in between. So the first few days after chemo, I was kind of okay, 3 to 4 days afterwards. And then day 4 hit in, and then I just went down rapidly. And I pretty much was the bedridden situation for the chemo. The fatigue was unreal. I was sleeping probably 18 hours a day. I was sick in between. I had every symptom, as my oncologist said. And then a few weeks later, again, as part of that process, I've noticed my hair was falling out, which of course they tell you up front you might lose your hair, but I did use a cold cap. That we did have that conversation. I did use a cold cap. But of course you forget the cold cap, I won't lie, it was probably a bit too big for me, so it wasn't the most successful, but it was really successful for my other colleagues that was in the chemo ward. I was just one of the ones that it didn't work for. So please, ladies and men, if you're doing it, do it, because I've seen fantastic results with that. But it didn't work for me. And it's weird because you think of your hair falling out, but you forget about your hair on your hands and your arm, your rest of your body, your eyebrows, your eyelashes. And the only thing I thought of was my head. And so a few weeks later, all my hair did start coming out. I had very long curly hair. It all came out very quickly. And then I was on that conveyor belt, as I call it, of chemotherapy, where you go in, you get your blood tests done, they check you for COVID, and then if all was good, I'd have chemo on the Friday, and then the week later, the oncologist would ring, how's it going? They give you a stack of medication, and just a bit of advice is take every bit of it. If you've got sickness, nauseous, if you can't sleep or you're getting too much sleep, they give it's so well versed. They ring you all the time to find out what your symptoms are, and they were fantastic. And I have to say how well the chemo nurses is, because when I did chemo, you're by yourself. I was in there for 5 hours. You're not allowed. Your family drops you off at reception outside in the car park. You walk in. It's a lonely road, I won't lie. You're in there with other patients that's gone through chemo with their the cold cap perhaps on them, and there was some men as well in there, men and women, and everyone's in their own zone, and they're in there for several hours. No one really talks. It's not a fun place to be, I won't lie. And maybe with COVID, because we had the masks on, it was very scary. It was a very scary place to be. It was a very lonely place. So the chemo nurses were fantastic. I can never say so much about them. They were ran riot, they were everywhere, but they were my saving grace. They kept us sane in all those dark times. And the chemo finished then after, so I had one at Christmas Eve, another chemo, which was a horrible time because it's coming up to Christmas. But and after that one, I'd moved on to the doxycycline, which is kind of the final one of my treatment. And I had a lot of effects of the doxycycline on my feet and on my nerves, and a lot of burning sensations. So they moved me after that one to weekly paclitaxel until the end of February. So then I went on to weekly chemo, which was a little bit better. It was still pretty rough because the damage, I think, was done previously, if that makes sense. But it was survivable from that perspective. But without question, during those chemo times, I won't lie, I did question, should I continue? Because I thought, I'm healthy, I've got it taken out of me in theory. Yes, it may have spread, but I feel really healthy, I feel really fit, and this chemo is just taking me really down. But you know, it's a lifesaver. So without question, I did all that research to think, should I stop it? And I never did, because my oncologist, all the research I'd done, I wouldn't have used alternative medicine or alternative treatment from my personal perspective. And then at the end of all the chemo, they said, okay, Lisa, next bit of your treatment now is the radiotherapy. So we'll have 25 blasts of radiotherapy, and that's every day. So that was every day pretty much for April to May. And that was fine. I won't lie, I breezed through that. I was bouncing in because I had a month between chemo radiotherapy. I turned up, the staff were fantastic. Got the blasting, got the zaps, went home fine. Yes, I was a little bit tired, I won't lie, I was a little bit tired, but nothing compared to the fatigue and all the issues I had with chemo. So I was really good, you know, relatively, it's all relative, isn't it? And then at the end of it, they kind of said, okay, we'll do some bone density scans for the next piece of the treatment. So the kind of active treatment was finished, and the next bit then was the hormone treatment for 10 years. And also then I was on another treatment called hyaluronic acid for the next 3 to 5 years. So my breast cancer was estrogen positive as well, which I guess is a good thing, because I think I won't say it's more treatable, but it's a well-trodden road. It was a very dark time all of it through. I think probably COVID made it worse, I won't lie. Of course it did, you're by yourself. But the treatment and all these services were closed, so there was no one to pop into Maggie's, there was no groups around, even through Zoom. And you don't want to go onto Zoom that you've never met people to talk about cancer, that it's so personal and everything you've gone through and all your body that it goes through. But the chemo nurses, I will not lie, and the oncologists kept me sane, because they were the only ones I seen every week from October till the end of May, bar my husband and my children. Yeah, so I'm good now. I'm doing well. I'm fit. I'm healthy. I will get back to do mud runs when they're back on again, without question. So that's kind of a bit of my diagnosis and a bit of my journey, really.
Lisa, I'm going to pass over to Gordon because I just listened to your story, and all I would say is, considering you finished your treatment in May, you look unreal. It's so good to see you now, because you've spoken so honestly there, and it's not easy to hear. And what you do really well, I think, is that you tell the story and you're saying it in an optimistic and a positive way. But it sounds like it was really, really tough. So I'm glad that you are where you are. But Gordon, I don't know if there's any points that you want to pick up after Lisa's story.
Yeah, and they're all very positive. I mean, Lisa tells a great story. She's very knowledgeable about her treatment, which is great. She brought to life some of the things we talked about. She found a lump. She went to a one-stop clinic. She got all her tests done in the same day. She was partly prepared for the treatment discussion, and I'll maybe come back to treatment at the end. But you know, I think it sounds to me like you've had first-class treatment. You know,
Yes.
You've had all the things that you should have had done, which is great. And I think the thing I'd like to ask you about is, one of the challenges for consultant surgeons and oncologists and patients is getting the right balance between telling you all the pros and cons of every treatment and then helping you to make a decision. And in my experience, despite doing that, the majority of patients still want guided in some way about what the consultant thinks, or what the multidisciplinary team that sits behind that consultant think. What was your experience of that, and how you think that could be improved?
Yeah, I agree, Gordon, absolutely, because when they tell you that devastating news and they give you those options, you kind of want them to take you, say, actually, this is what you need to do. No option, this is what you need to do. These are the reasons why you need to do it. And also, when we had the discussion about the treatments and the options and all the other bits, is to say, this is the reason we need to do it. This is what we're doing for you. And kind of that's it, and it's taken out of your hands. I felt there was choices, and I was not in a position to make those choices. Initially there was choices, and then you have that discussion where I say, hang on, I haven't got a clue, I'm not an expert here. And I think maybe that's where the oncologists and the surgeons need to take a bit more ownership, to say, we've seen this all before, Lisa, this is what you've got, this is what we believe is your treatment path. If you disagree with it, then obviously we'll have that discussion. But actually, this is a well-trodden road, and we believe this is the best for you. Because I realise the chemo is very personal. It's a different situation. It's tuned for your body and yourself. But the initial treatment, for sure, I think it should be less choice-driven and more the reasons why you have to do this. And the choice then is for you to say, actually, I don't want to do it, or I want to look for alternatives. That's the only choices that you should be given. So yes, Gordon, I think there's probably a little bit too, and I hear that from some of the other women in some of the groups, that there is choices given, and none of us are in that position, because all you hear about is the word cancer. It's devastating. It shortens your life, potentially death, and that's all you're thinking about initially.
Yeah, and I suppose there will be some people who want more information about all the tests. It has to be tailored to what you want. I think the other thing that I picked out is that you said that a lot of your consultations were by video conference. Is that right?
Yeah.
And I think it is incredibly hard. You know, a two-way discussion about treatment between doctor and patient is a dynamic thing, and it will change according to what the patient says, and also the patient's response, which may be non-verbal as well as verbal. Incredibly hard to do that on video conference, and to pick up those small nuances about what someone's thinking about what you're telling them. And so I know there is a role for video conference in medicine, but I honestly, I know that was forced upon us, but I would not like to see that become the default position for discussions about cancer treatment.
Yeah, I agree, because my surgeons it was both phone and video conferencing. But I remember once when they rang me, and I was in a car park waiting for my husband, who'd popped to the shops, and they rang me on the phone, and she said, I just want to see how your scars are doing. So I was there with my phone. in the car park because she was supposed to have rang 2 hours later, and they give you an appointment to say, we'll ring you at 1. It was about 10 o'clock in the morning. Said, is it okay to talk now? And I said, well, I'm in the car park, it's a bit awkward. Well, while you're here, can we have a look at your scars? So that was it was funny. And it's nice to have those kind of funny moments. And we laughed about it. I know I seen the surgeon a few months back to go in and thank them. And we did laugh about that in the car park, where I put up curtains around me or blankets where my kids have in the back. So it was but it's good to have those memories. You have the funny times off the bad journey. But you're absolutely right, Gordon. I think it's critical for probably lots of treatments, but certainly for cancer, that it's on a one-to-one basis, that it's face-to-face, that it's not remote, because it just doesn't work. I know the conversations I had, if it's video call or on the phone, I did say by, I think, Christmas time that I'd like to see my oncologist face-to-face, if that was possible. And luckily, he rang me back and said, yeah, Lisa, of course you can. There's no reason why we can't. But that was denied a few weeks previously. But then I think by Christmas, I guess they got to know me. Perhaps they got to know how we work. And then after Christmas, I did see them. January, I started to see them face to face, which was fantastic. That worked really well.
Lisa, thank you so much for sharing your story today. You speak so brilliantly, and I know you've helped so many people, and we can't thank you enough. So it's amazing to see where you are today. I don't think it's right to say happy anniversary in terms of 1 year today, but I'm delighted you are where you are, and yeah, keep going, and we'll check in when you've done some more mud running, I guess.
Yes, I think so. But the key to it, men and women out there, is you do have to stay positive. It's really dark. I did lots of research, maybe too much and too many groups, and I ended up switching off those groups because there was always the negative on a lot of those groups. Do your own thing, run your own race, don't heed what anybody else says about you, positive or negative. Listen to the experts because they've been down this, they live it and breathe it every day. You have to stay positive, you really do. There's times when you'll be crying and in an absolute state, and that's fine, you need to vent out. But stay positive, because people can get dragged down into a deeper rabbit hole, and you need that mental positive attitude. So I just took it as read. You know, the treatments worked. When you break your arm, I guess you get treated. It sounds wrong to say, I know it's not the same severity, of course it's not, but I have to take the faith in the science and the medicine. So thank you, Jamie.
No, thank you, and you know better than anyone else, so I suggest you take that advice on board. I definitely will. Thank you, Lisa. We're now going to hear from Jessica, who was diagnosed with bowel cancer. Jessica is going to come on and share her story as well. Jessica, just for context, has 2 young children. She's a financial advisor, not into mud running so much, but a fan of dance and Peloton workouts. Jessica, thank you so much as well for joining us today. How's things with you?
Yes, good, thank you.
Amazing, thank you so much, good to see you. Again, you've got a very different journey, obviously, for different cancer as well. I guess the questions we'll ask will be very similar, but would you mind sharing a little bit with us about what made you go for your initial checkup? What was unusual in your case?
Yeah, so I guess the only real symptom that made me go and see a doctor was that I had really bad stomach cramps. The type that were just so excruciating that I couldn't move, I couldn't do anything while they were there. They actually reminded me of labour pains, which is why I wanted to go and see my doctor, because I had only previously had my baby 7 months before. So I thought it could have something to do with that. In terms of the other kind of main symptoms of bowel cancer, I didn't really have them or notice them because of the timing. And I feel like this is a really good way of saying it's so important to see people in person, especially your GP, because it was when I went to see her that she took one look at me and she said, I think you look anemic, so I want to do a blood test. So she'd scheduled me in for an ultrasound, and I was waiting for that appointment. In the meantime, she did a blood test for me, and when the results came back and it showed that my iron levels were really low, she knew that just something wasn't quite right. She almost had a bit of a sixth sense about it. So she flagged that up really quickly. She did all of the examinations that she needed to do. to make sure that I was going to be seen really quickly. And it was then that I was referred to a specialist, a gastro specialist. From that point, I then had a MRI scan, and then I had a colonoscopy, and it was then that it was diagnosed. So yeah, so on the same day that I had the colonoscopy, he diagnosed me. He said, I'm pretty sure, I'm 95% sure that it's cancer. So you kind of take from that, but yeah.
So things escalated pretty quickly for you from diagnosis to the sort of, what at that point, did you then immediately have a conversation about treatment, or kind of what was the next, was there a wait period, kind of what was the journey like?
Yeah, I think he wanted to just get it out there to me that you know, it is cancer. He was pretty certain that it was cancer, but he was sure that it would be treatable. And he also prepared me for the fact that I would likely have chemotherapy because I was young and healthy. If it just took away a small percentage of the chance of it returning, then they would probably do it. So I knew from day one that that was likely for me. And then he scheduled in a CT scan to check that it hadn't gone anywhere else, and then a follow-up appointment for a week later. So that gave me a little bit of headspace to just have a little think, get together some questions, and then I could go back to him a week later and go through everything in more detail.
You appear to take it in your stride unbelievably well, Jessica. Like, I would be a complete mess. And Lisa kind of touched on like the sort of emotional side of things, the mental challenges, like the wait periods and things like that. It seems like you did get some great treatment and it was quite quick and fast moving. What was your kind of thoughts, feelings and emotions though around everything? Like, you hear so many people share their, you know, it's not going to happen to me. You seem very level-headed about everything.
I'm not going to lie, it was a real shock. I don't think I had prepared myself for the fact that it could be that. I thought it was just going to be something a bit more routine, maybe some inflammation or something like that. But I think having two young children, I had a 3-year-old and a 7-month-old. So you kind of just have to get on with things, really. Although it was on my mind a lot of the time, you know, I'd be thinking about it, but then I'd be sitting with my daughter at Disney on Ice, and it just felt really surreal that it was all happening to me. But yeah, I've got a good kind of support network around me, so people were looking after me, and it was a bit difficult because it all happened just before Christmas, so there was that kind of added element of things were a little bit delayed because of Christmas and stuff like that. So but it didn't take too long. It was probably about 6 weeks between diagnosis and having the operation. So
wow. Being a mum never stops, does it, really? I guess there's no time off. You can tell. I'm going to pass over to Gordon in a second, but if you could then just kind of talk us through your treatment and what that experience in there, like, Gordon, follow up after that.
Yeah, so I had a operation to remove part of my colon. So they removed a bit more than where the cancer was, just to make sure that he was joining two bits that were healthy. And he removed the surrounding lymph nodes as well. So there was 43 removed. So when the results came back, one of them had cancer in them. So it spread to one of the lymph nodes out of the 43. And it had also grown a little bit into the bowel wall as well. So for that reason, they did recommend that I should have chemotherapy after. So the operation went well and I recovered really well from it. About 6 weeks later, they wanted to start chemo. So they started me on a combination, I think they refer to it as K-pox. I'd have a drip on the first day. And then I'd have 2 weeks of tablets that I could take at home, and then I'd have a week break. So I had 4 cycles of that. And I guess another thing that they did was they had to check for a DPD deficiency, which is I think it's something to do with a type of gene, which they looked for right at the beginning, and it turns out that I did have that. So they had to amend the tablets that I was taking because it can potentially make the side effects worse. So they did that for me, and they said they'd see how I got on. But then, of course, COVID kicked off, and they kept it at the half level because they didn't want to risk me kind of getting any worse side effects at that point.
Wow, as if it wasn't enough to deal with, that just drops in there as well. Gordon, I'm going to let you, if you have any questions or anything to add.
Yeah, I just think, you know, Jessica, just like Lisa, you know, is very well informed about all our treatment, and so you clearly had, you know, your treatment well explained to you. You understand the different parts of it. So I suppose, and I think yours is a great example of a really good kind of diagnostic triage. Lots of people get stomach pain and abdominal cramps, but you mentioned that when you saw your GP, they said you look anemic. That's incredibly hard to do if we were on a Zoom meeting. You know, that's a real face-to-face. That's why you go to the doctor when you're unwell, and that's part of the examination, if you like, just watching how someone walks into your room and what's your first kind of things that you notice. So I think that's really powerful. But yeah, I just wanted to ask, do you think you were obviously given information about the different treatments that you could have? Did you think there's any way that could be improved? Did you feel you had enough information, or too much, or not enough? But I'm just interested to know this, just as I asked them, as I asked Lisa.
Yeah, I think I was grateful that they told me what they thought I should do, because I wasn't in the headspace to make that sort of decision. I had so much to do anyway. I didn't really want to go off and start researching different things. I wanted a medical professional to just tell me what they thought was the best option. They gave me information about it, information to read, to take home with me, and then I could come back with any questions afterwards as well. So I think personally it was the right amount of information. Yeah.
That's great. It's great to see you so positive about your treatment, looking really well. You know, great example of someone be giving the right treatment and really responding positively to that. So I wish you well, you know, going forward.
Thank you.
I think, yeah, Gordon, that's exactly what I kind of, the last thing I would say. And Lisa, if you're still there, maybe I'll just get Lisa to turn the camera on as well. I think we can all end this one together. There you are. Is that the conversations that we're having and we will continue to have are really, really tough, but you're both examples of, like Gordon's highlighted, some really, really good treatment processes. You've had some great care. And although what you've been through is horrific, you both look great and you're both recovered and you're going to go on and do some amazing things. So there's been lots of questions that we've had today, and I'm sure that sharing your stories has helped. Gordon, as always, your knowledge has helped invaluably. But the key message is, if you've had a question that hasn't been answered, then make sure you follow up with it. Don't leave it. Why is it that you've asked your question here? If you've asked it here, it's clearly on your mind and it's something that you should go and get checked out. So whether that's with a GP, by the sounds of it, face-to-face, whether it's a screening, look at all of the support you have available to you, and absolutely make sure that you go and get those checks done, because clearly there is good pathways in place and you'll get the best care possible. And we're all really, really fortunate for that. So that is it for today's session. Gordon, Jessica, Lisa, you guys have been amazing. Thank you so much for joining us today. Everyone that's watching, I hope this has been helpful. Please do let us know what you thought in the feedback. Continue the conversations, share these videos far and wide. We'll upload this to our YouTube channel so that it's available for everyone to view whenever you would like. And in the meantime, thank you again, take care, and hopefully we'll see you again soon for some more events.
Thanks, Jamie. Thanks all. Bye-bye.
Yeah, thank you very much. Bye, Jamie.
Bye.